Hi, thanks for watching. Let's talk about cancer of the ovary. Cancer of the ovary is the 11th most frequent cause of cancer in women. It's the 5th leading cause of cancer-related death in women. There will be about 22,000 women diagnosed with the disease this year, 14,000 deaths because of the disease. It's the most fatal gynecologic cancer. Overall, the prevalence appears greatest in the Caucasian population, then the Hispanic population, then the Asian Pacific population, then the African American population, and finally in the American Indians. Highest in women of Ashkenazi Jewish heritage, also high in French Canadians, Dutch, Icelandics. Throughout the world, it's high in Russia, high in the United Kingdom, relatively low in China. It's rare before age 30, but there's an increase with age, with a dramatic increase over age 50. The average age of diagnosis is about 62, ranged between 50 and 70, mostly during the postmenopausal years, once the ovaries stop producing the estrogen. Good news is, during the past decade, we've had a reduction in the incidence by a little more than 1% per year, and a reduction in the mortality of a little more than 1.5% per year. And it seems like this is probably due to a decrease in the use of hormone replacement therapy in women after the menopause, and an increase in use of the birth control pill. Well, if we look at the overall survival, Stage 1 disease, looking at 5-year survival, is about 90%. Stage 2 disease, 5-year survival, is about 70%. But once we get to Stage 3 or Stage 4, it's less than 20%. Now, the unfortunate fact is that 70% of the women are going to present with Stage 3 or Stage 4 disease. So that means the overall survival of cancer of the ovary, 5-year survival, is going to be about 50%. There are many different types of cells in the ovary. The kind that produce the epithelial ovarian cancer, of course, the epithelial cells, that accounts for about 90 to 95% of all tumors, in spite of the fact that there are lots of other kind of cells. Now, there are a variety of different types of ovarian carcinoma. We have the high-grade serous carcinoma. That accounts for about 70 to 80% of all ovarian cancers. Then we have smaller incidences of low-grade serous carcinoma, or endometrioid carcinoma, or mucinous carcinoma, clear cell carcinoma. And those make a difference because the latter group seem not to be as lethal. They tend to come on at an earlier age while women are still having their periods, about 10% associated with endometriosis and inflammation. Those are the low-grade serous carcinomas, the endometrioid carcinomas, the clear cell, and the mucinous. They have a certain type of genetic signature associated with them. Now, the high-grade serous carcinoma has a completely different type of genetic abnormality. They're often fatal, diagnosed late, tend to arise in the fallopian tube. The 10-year mortality is about 70%. So we have the ovarian carcinoma. It's an adenocarcinoma. It tends to begin outside the ovary in the fallopian tube, or maybe the endometrium, or maybe even the lining of the peritoneal cavity. It's not a single disease. We've mentioned that. Frequently recurs, and once it recurs, it's still treatable, but unfortunately it's incurable. But we have new medicines, and these new medicines increase the progression-free survival, even if they don't increase the overall survival. Now, there's a genetic predisposition to ovarian cancer. About 15% of the women have an ovarian predisposition, or cancer predisposition. And that's with the BRCA1, BRCA2 gene. Those are typically associated with cancer of the breast, but they're also associated with cancer of the ovary. Well, they're needed, the normal function of those genes is needed for DNA repair. But not all mutations in the BRCA1, BRCA2 are identical. It depends where along the course of this very long gene there happens to be a mutation. So some mutations cause cancer, some mutations don't cause cancer, and some mutations we're just actually not sure about. But as an idea about how important the mutations can be, if we look overall in the general population, well, the BRCA1, BRCA2 mutations present in somewhere between 1 in 300, 1 in 500 women, but among the women of Ashkenazi Jewish heritage, it's about 1 in 40. And as a matter of fact, about 50% of those women who carried the abnormality in BRCA1, BRCA2 don't even have a family history of the disease. But again, getting back to the importance of the gene, overall, the likelihood of a woman, just in general society, of having cancer of the ovary by the time she's age 80 is about 1.5 to 2%. On the other hand, if that woman carries the BRCA1 gene, and it's abnormal, then the toll increases to 40%. If it's BRCA2 gene, it increases to about 18%. And then there's another genetic abnormality, it's called the Lynch syndrome, and that carries about a 10% risk of developing cancer of the ovary. So women who develop cancer of the ovary at a relatively early age, less than 50, probably genetic testing is in order to help some of the other family members know what they might be up against. So the BRCA1, BRCA2, very important in repairing genetic abnormalities, but we can also have abnormalities of those genes, but not the gene itself. It might be an area right before the gene, the promoter of the gene. So we can examine the BRCA1, BRCA2 and find they work perfectly normally, but it's the instructions for the gene that might be amiss. And just to show you the importance of, say, BRCA2, which has an increased survival compared to the BRCA1 gene, well, it also, the BRCA2, might be associated with cancer of the prostate or cancer of the pancreas or malignant melanoma, but it increases the likelihood that you'll respond to the chemotherapy. So that might be good news. So the Lynch syndrome, it's about 10 to 15% of the genetic cause. Used to be called the hereditary non-polyposis colorectal cancer. Now we call it the hereditary family cancer syndrome, named after Dr. Lynch. But this type of genetic abnormality seems to be associated with the endometrioid or the clear cell carcinoma, also associated with endometrial carcinoma and urinary tract carcinoma, stomach carcinoma, small intestinal carcinoma, biliary tract carcinomas. But the good news with the Lynch syndrome associated ovarian cancer tends to occur early, age 48, and half of the cases at least are stage 1. So that's good news. So genetic predispositions are present far beyond just those 3 conditions that I mentioned. There are lots of genetic abnormalities, some in cancer syndrome, some not in cancer syndrome. But the most important genetic abnormality happens to be in P53. And when we have a genetic abnormality, that's a checkpoint inhibitor. When we have an abnormality in the P53, that tends to be associated with the high-grade serous carcinomas. Now, people talk about risk factors. What do you do that could increase the risk or decrease the risk? People talk about an increased risk associated with not ever having been pregnant or having an early age. The onset of the period is late age at the menopause, not breastfeeding. Well, all of those seem to be important, but not for the high-grade serous carcinoma, the one that's most common and the one that's most deadly. Also, there are some benign gynecologic conditions that might be associated with carcinoma of the ovary, endometriosis, as mentioned, and polycystic ovary disease, maybe even pelvic inflammatory disease. Well, if you breastfeed for less than 6 months, you might reduce your risk of carcinoma of the ovary by about 21%, increase your breastfeeding from 6 months to 12 months, maybe you can reduce by about 30% your risk. Have 1 child, reduce your risk by about 30%. Have 2 children, reduce your risk by about 40%. If you use a birth control pill, especially if you happen to have the BRCA1, BRCA2 mutation, you might be able to reduce your risk of ovarian cancer by about 50% as long as you take the pills for at least 5 years. But with some of the newer pills with lower concentration of estrogen, you might have to take them for about 10 years. Now, if you use hormone replacement therapy and just use the estrogen, you might increase your risk by about 25%. Combine it with progesterone, might increase your risk total only about 10%, and probably increase your risk even if you just use the progesterone itself. Now, it would appear in women who are less than age 52, who have severe symptoms of menopause, that a short-term use of hormone replacement therapy of less than 5 years might not significantly increase the risk. Well, the risk will be increased if you're obese, especially if you gain more than 10 pounds after the menopause, if you don't have any physical activity, that increases the risk. Cigarette smoking increases the risk. There's a question about, does depression increase the risk? And then you hear all of these lawsuits about talcum powder increase the risk. Actually, there's significant debate about that. You can decrease the risk with tubal ligation, decrease the risk 10-15%. Hysterectomy, of course, or one or both ovaries, if they're removed, that obviously decreases the risk. And you can decrease the risk by taking aspirin or nonsteroidal anti-inflammatory drugs. And of course, in those women who are carriers of the BRCA1, BRCA2, then of course recommendation is bilateral removal of the ovary and the tube. That certainly is going to decrease the risk. Screening. We don't have any approved screening. We don't have any screening that makes sense for the general population. The pap smear appears to be pretty worthless for the purpose. There's the CA125 that people talk about. It's also known as the mucin 16. Well, unfortunately, it's not very good for screening. And unfortunately, it's also increased in women who have fibroids or ovarian cysts, or women who are pregnant or have liver disease infection, even in normal women. So that doesn't help us. Well, how about either the transvaginal or the transabdominal ultrasound examination? That ought to be able to detect something at a relatively early stage, and surprisingly it doesn't. It doesn't seem to be very effective. And in fact, if we combine the ultrasound with the CA125, all we do is increase the number of women who are going to have surgery, but we don't increase the likelihood of survival. So we don't really at the present time have any good screening. And anyway, screening is based on the concept that if we make the diagnosis relatively early, that we'll be able to cure the disease and increase the survival. But there's a problem. And the problem is that, for instance, stage 1 disease, where we say the survival is 90% for 5 years, well, that's because the tumors are different. We're not talking about the high-grade serous carcinomas. They're going to be stage 3, 4 by the time we can find them. So unfortunately, there's a question about how valuable some of our screenings really are. That's the topic of a different conversation, but at least as far as cancer of the ovary is concerned, it's a different type of tumor that we find at stage 1 versus we find at stage 3 or 4. Now, if a woman happens to carry the BRCA1, BRCA2 gene, then it's recommended she have screening every 6 months with the CA125 and the transvaginal ultrasound. But we don't have any evidence that that really is going to make any difference. What are the symptoms? How do we make the diagnosis? Well, several months before the diagnosis is made, generally, women start complaining of some bloating or maybe some easy fullness that occurs with eating just a short amount of food or small amount of food. We call it early satiety. Maybe some women complain of nausea or vomiting or diarrhea or constipation or new onset reflux or altered bowel habits. Or they suffer from abdominal distension or abdominal or back pain or maybe some urinary symptoms because of the pressure of the tumor. Sometimes people develop shortness of breath. It's because of fluid accumulating in the belly that pushes up on the diaphragm, or maybe because there's an increased incidence of DVT associated with cancer. Maybe a person had a pulmonary embolism, maybe swollen leg, blood clot in the lung. Sometimes it's difficult to make the diagnosis. Oftentimes may be mistaken for gastrointestinal carcinoma or metastatic breast cancer, maybe a cancer metastatic to the ovary. But by the time the woman gets to the doctor, generally we have a dominant pelvic mass with evidence of carcinomatosis spread throughout the belly with abdominal distension and ascites. History, physical examination, obviously very important. Then there's the CAT scan, maybe an MRI. Laparoscopic examination to find out what's going on. Biopsy, of course. Then there's a question about the laparoscopic or the laparotomy type examination. But for the treatment, we need the hysterectomy, removal of the ovaries and the fallopian tubes, the omentum. We need to inspect the peritoneal surfaces to make sure there aren't any suspicious areas, and if there are, we need to biopsy them. We need to perform some pelvic washing to examine for cells that might be present, examine the bowel, examine the bladder. And up until 2019, it was thought that we should dissect the nodes in the pelvis and around the aorta. But in early 2019, the authorities suggested that, that really doesn't seem to make any difference. Just look at the nodes, and if the nodes look okay, you don't have to touch them. And as a matter of fact, we find, compared to the early examination, initial examination, oftentimes there was occult disease that was not originally diagnosed, and that leads to an upgrading in a significant percentage of the women, because the diaphragm wasn't visualized appropriately, or the omentum wasn't biopsied, because there's tumor that's hidden somewhere. So we really need a gynecologic oncologist, a gynecologist who specializes in cancer surgery. That seems to be the best outcome compared to, say, a general surgeon or a general gynecologist. Well, you need to get rid of all of the tumor in order to have the best outcome. Sometimes you can't get rid of all of the tumor. Sometimes it's spread too widely. And if you leave more than a centimeter of the tumor intact, we're not going to have a good outcome. Actually, you need to get all of the tumor out in order to get the best outcome. Now, staging of the disease. You have stage 1 if it's confined to the ovary and the fallopian tube, but it's stage 2 if it spreads outside the ovary and the fallopian tube and stays inside the pelvis and below the pelvic brim. It's stage 3 when it's outside the pelvis or it's in the nodes, and it's stage 4 when it's metastatic more widely. The hallmark of the disease is that the tumor gets to the surface of the ovary. Once it gets to the surface of the ovary, then the cells are shed into the peritoneal fluid, and then it disseminates from the peritoneal fluid into the pelvis and the diaphragm and the liver and the bowel and the omentum. And surprisingly, it can even go through the diaphragm into the pleura. Now, if a woman is diagnosed, probably needs to have BRCA1, BRCA2 genetic testing, especially if the woman is less than age 50, to inform the family. We also know that therapy is debulking surgery followed by chemotherapy. But in some women, we can't get all of the tumor out, and it's apparent on the laparoscopy that can't get all the tumor out. So oftentimes, start off with 3 rounds of chemotherapy. We call that neoadjuvant chemotherapy, and then do debulking surgery, and then go back and have another at least 3 rounds of chemotherapy. But unfortunately, most women are going to present with stage 3 or stage 4 disease. And that means that, unfortunately, even the surgery is not going to be able to be successful. So we go to the chemotherapy, and the chemotherapy is platinum-based, and it's combined with Taxol-based therapy, and it's begun 2 to 4 weeks after the surgery. If there's a greater delay, that reduces the survival. In Japan, they have dose-dense chemotherapy, but that really doesn't seem to work here in America. Generally, over a period of time, the tumor becomes resistant to the platinum, and that causes a problem, obviously. We add Avastin, and Avastin is a relatively new kind of therapy. It's what we call a VEGF inhibitor, vascular endothelial growth factor inhibitor, that prevents some of the new blood vessels from being formed. That seems to be helpful, but we have new therapy, and the new therapy has a peculiar name. It's called poly-ADP ribose polymerase inhibitor, or we could simply call it a PARP inhibitor. These are medicines like Rubraca and Lynparza, and they seem to be relatively good. Originally, when they first came out, the FDA said, well, you could use them after 3 rounds of chemotherapy, after 3 different types of chemotherapy, after failure of 3 different types of chemotherapy. But in December of 2018, they said, these drugs are pretty good. Why don't you use them after the first line of chemotherapy? And actually, they've been able to reduce progression quite significantly. So we find that the 3-year survival without disease progression in people who are treated with placebo is only about 25-30%. But using these PARP inhibitors, it's around 60%. Yes, they have some side effects, but compared to the other outcome, it probably sounds pretty good. Then we have some interest in the drugs like Opdivo and Keytruda and Yervoy. Whether that's going to work out, don't know. There are a lot of other chemotherapies, but unfortunately they don't seem to provide all that much benefit. Now, unfortunately, We frequently have recurrence of the disease, and the question is, should we do some debulking surgery? There's some question about how valuable that is. Follow-up, the idea is that women should be routinely examined, have the CA-125 evaluated now for diagnostic purposes, not for screening purposes. So the CA-125, follow that. Whether we actually make much difference in the ultimate outcome of the disease by early detection of recurrence, that remains to be seen, surprisingly. Well, doctors tend to pay attention to the tumor. How is the tumor doing? How much is the tumor shrinking? Well, women are interested in, hey, what's my outcome? Am I able to go to work? Am I able to be emotionally calm? What's my social life going to be? How functional am I going to be? Do I suffer from a lot of fatigue or nausea or vomiting or constipation? Do I lose my appetite? Am I in pain? How can I sleep? Do I feel ill all of the time? Well, those are issues that need to be addressed, not just how the tumor is doing. The ultimate outcome tends to be malignant bowel obstruction. Death seems to be from cancer progression. And unfortunately, that's where we stand right now with cancer of the ovary. It's the most lethal gynecologic cancer we have. Unfortunately, the early symptoms are nonspecific, and they tend to occur relatively late in the course of the disease. There's no screening at the present time. And unfortunately, we don't have the greatest of therapies, but the therapies seem to be improving. Seem to be improving to the point where even if we can't cure the disease, we can certainly extend survival. Anyway, thanks for watching. If you enjoyed the show, please tell a friend. Maybe subscribe so you'll be notified when we post new videos. I appreciate your interest. I'm Dr. Ken Landau.